So for the nursing staff from Palo Alto, how are you today? Absolutely. Great to hear it. Also, welcome, Dr. Jack. Very nice to meet you. Thanks for coming out. I would like to introduce, we have a couple of special guests. The chief nurse from Fresno, Dr. Patricia Richardson, is around someplace. I'm not quite sure if she's in here or not, but she's made the trip. And also, how many here from VA San Francisco? Anybody here? Very good. Welcome. Thank you. A couple of things before I turn it over to David. First, I want to thank the team, the ARC collaborative team. They got this started with our looking at our readmission rates for both med-surg and mental health. I think one important piece of the ARC collaborative is that it is team-based. And I think the point that I'm bringing here this morning is to hopefully emphasize the team and knowing that the VHA will be successful in the future because of its teams and not because of individuals or not because of specific agendas. I think at Palo Alto, I can say in all honesty, I am seeing now, even since the first day I've come, a real cohesence of teamwork. And I'm very proud of that. And I want to thank you for that and thank our administrative executive team for supporting that as well. Team, to me, is, together everyone achieves more. So the ARC is here. Collaboratively, we are achieving more, and we are very patient-centered. And so that's actually the best of all worlds. I want to thank David. I want to thank Alicia Bates for all their hard work in putting this together. I know we're going to be thanking the Betty Moore Foundation staff a little bit later. But a couple of other things I wanted to mention, and unfortunately I need my glasses. And before we go on, everybody needs to notice my shoes, because I do have the red patent leather shoes on today. Thank you. One of the things that we want to make sure we look at is getting our readmission rates. Our goal was 30% for med-surg and 10% for mental health. And so again, as the VA moves forward in 2012, the cost of the readmissions, the lack of efficiency with regard to readmissions, and the patient revolving with the readmissions is something that we also want to make sure we look at and see how we can use Project Red to achieve those goals. So thank you very much. I want to also look for the model in terms of being a set project of this is one of many ways and where we'll put the model so that, again, it's just not for the med-surg or mental health. We'll look to see it discharging across the board. We have geriatrics, we have rehab patients, so perhaps we can replicate this model as we implement it at Palo Alto and move forward. But last and not least, again, it goes back to the change, and the change that we have in 2012, the change that we have for national health care, the change that we all need to face, and as I learned at the leadership conference, change is hard. So this may not be easy. This may not be something that we really wanted to dabble in, but it is absolutely something that we need to address to ensure success. And success is not our success. Success is the outstanding veteran care that we provide every day. So I want to thank you for coming. Thank you for your attention. Welcome our guest, and I'll turn it over to David.
Now you see why we asked her to speak, right? Additionally, I wanted to mention that Northern Cal, I know that Jacob and I believe one other, there you go, there's two. Thank you for coming as well. I have just a few introductions to do. The first thing I want to do is, could all the staff nurses in the room stand up? There's 25% of you here are staff nurses. So, we wanted to emphasize that because we know that that's really where the rubber meets the road, and that's where we have the largest impact. And those of us who have been working on ARC have been very, very thankful for all the staff nurse input. I did send out an email. Those people who were involved in our ARC collaborative, there's a lot of us. And I told, Alicia sent out an email and said, please, wear red. And so I was feeling really bad about that. And I got on the email and I said, okay, let's be clear. Nobody please go buy an all red pantsuit. A splash of red. So I have two members of our team who are providers. I'm not going to give you their names, but I just want to let you know what they wanted to wear. I will let you take a guess at which providers these are, and if you have them right, I'll let you know. This is the next gentleman in red. That's what we have to work with on this side of the house. So we're very thankful. Actually, both these, the APE and the Zoot Suiter, have been very integral to our success with ARC. It's such a collaborative team. I can't express enough how thankful we are. My next introduction is Dr. Elizabeth Malcolm, who never wears an APE suit or a Zoot suit. You can see we asked for how they'd like us to lead them in. Both these next two people we're gonna introduce are very quiet and very subtle and don't take nearly the acknowledgement that they should receive. We're so thankful to be working with both of them. Liz Malcolm is trained as an internist and health services researcher. She's the program officer at the Gordon and Betty Moore Foundation, and her current work is centered around improving transitions of care and reducing readmissions at Bay Area hospitals, and she's one of the primary reasons why we're here today. Elizabeth.
I thank you all so much for coming. We're really excited about having you here. This work comes out of our Avoiding Readmissions Through Collaboration work that is really, we invited all hospitals in California, but we're really trying to double down on the Bay Area hospitals to reduce avoidable readmissions and improve the quality of care for patients. And you received one of, I think, 7 planning grants to create a plan to reduce readmissions at your hospital. And we have been delighted with the work that David and his team has done. And we're really looking forward to seeing how successful you are in this task. This is just a terrific day. So thank you, David. Thank you for coming, and welcome to the Moore Foundation.
Next, we have Pat Teskey. She's serving as the Improvement Advisor for the Avoiding Readmissions Collaborative. She works closely with all of the planning grantees to develop and implement readmission reduction approaches. The thing that this is in quotes, okay, so you can't say I'm being rude. Excellent nagging skills. All I'm doing is validating that aspect. Pat.
Well, as anyone who's ever tried to gather data from many, many hospitals knows, you need excellent nagging skills. And my husband will validate that as well, I'm sure. So again, thank you and welcome. I have been working closely with all of the planning grantees, and I've been welcomed on all of the teams. And it's been personally very rewarding for me and professionally rewarding. I've spent many years kind of in the community hospital realm, and this is the first time I've worked as closely with the veterans and with some of the other large public hospitals, and the dedication that you have to your patients is so outstanding, and I applaud you for that. And it's exciting to see the teams come together. All of the different teams have taken a little bit different trajectory, and I remember the day I left the VA team, and I was so excited because, before it was kind of like puzzle pieces, and just all of a sudden it snapped together, and I was so excited. I called Liz on the phone, and I'm like, Liz, you won't believe it, they're on fire. And, from that day forward, it's been like, hyperdrive, and here we are today, and enjoy the day. It's going to be powered on from here. So thanks, David, and everybody else.
Thank you. And next we'll have Lily, who is the vice chair for our collaborative, come up and do some introductions.
Good morning, everyone. It is my honor to introduce Dr. Brian Jack and his team here today. Jessica Martin and Dr. Suzanne Mitchell. Dr. Brian Jack is the professor in family medicine in Boston University School of Medicine. He has completed a project in ARC, which is an Agency for Healthcare Research and Quality, patient safety portfolio, including re-engineering the hospital discharge for patient safety, which provided a in-depth analysis for hospital discharge process and devised the re-engineered discharge, which is called RED. That's why everybody is wearing red today. And this new process was then tested in the testing the re-engineered hospital discharge, a randomized control trial funded by ARC in partner in patient safety portfolio. He has completed a project called Virtual Patient Advocates to reduce ambulatory drug events that is using an innovative health information technology systems to monitor medication adverse events related to the transition from hospital to the ambulatory environment. He has recently completed a RO1 from National Heart, Lung, and Blood Institute that is testing a health information technology system that is assisting with providing the red. He's also completing a ARC action contract that has built a toolkit to assist to assist the hospitals in delivering the red, and is now testing this toolkit in 10 hospitals around the country. Is that right? He has actually authored over 90 peer-reviewed and papers and book chapters, and he has served on many grant review panels, including CDC, the Health Resources and Service Administration, National Institute of Child Health and Human Development. And he received his medical degree from University of Massachusetts Medical School, right? So he will be speaking about the background of project and how VA Hospital here, or maybe the whole visit, implement the RED. And then we'll talk about how to measure project RED outcomes and process measures, right? Alrighty, and the next speaker is actually for this afternoon is Ms. Jessica and Dr. Mitchell. Jessica is the program director for the Project RED and research at the Boston Medical Center. She oversees federally funded grants and contracts pertaining to transitions in care and health IT. She has over 8 years of experience in the clinical research and continues to consult on the neuroimaging and pharmacokinetic study design and implementations. Jessica holds a master's degree in clinical counseling psychology from Fairleigh-Dixon University in New Jersey and is about to complete her master's degree in public health at Boston University. Welcome you. And then the next one is Dr. Suzanne Mitchell. She's an assistant professor in family medicine at Boston University School of Medicine. She's a board-certified family physician and federally funded clinical researcher, studying transitions in care and the impact of a patient-doctor communication on the health disparities. She has over a decade of clinical experience caring for vulnerable populations and practices in clinical medicine in nursing home and hospital settings. Dr. Mitchell received her medical degree from Wake Forest University School of Medicine and holds a master's degree in clinical research from UCLA. And both Jessica and Dr. Mitchell will be providing training on discharge educator roles and discharge plan reinforcement phone calls this afternoon. Let's give them a round of applause to welcome the whole team, okay? Have fun. Now I'm gonna turn this to Dr. Jack, okay? Thank you.
It's a great pleasure to be here this morning. I feel like a rock star with this. And to be here in this beautiful part of the world that you live in. We arrived late last night and are ready and raring to go today to talk to you about Project RED. As Lee said, I am mostly a clinician. I've done research for many years. But my interest in readmissions and the transition work really emanated from my clinical work, both in the hospital, where for years I've worked with residents in the hospital on the service in the hospital, knowing that the patients that we're sending home aren't quite ready and prepared to care for themselves when they go home, and that we know that that person just isn't ready, and they're going to come back. And by the end of the year, the interns all know the frequent flyers who come back and back to the hospital. but we haven't paid much attention to it till recently, until suddenly clinical care, patient safety, and policy issues collide together, and that's where we are now, where readmissions is such a big deal. Also, my experience as a primary care physician in the clinic taught me that I would receive patients who had been in the hospital back to my clinic, sometimes at night, sometimes on Saturday morning, and I didn't have all the information necessary about what happened to that patient in the hospital. And that often led to not optimal decisions, and sometimes to be readmitted to the hospital. So about 10 years ago, we began to look very carefully at hospital transitions, first as a patient safety issue, and then later as a health policy issue. About 5 years ago, I was sitting in my own hospital, Boston Medical Center, the former Boston City Hospital in Boston, and my father was a patient. He has a pacemaker, congestive heart failure. The diagnosis related to the highest 30-day all-cause readmission rates in the country. He came in to have his pacemaker adjusted, not a big deal. His physicians had told him to stop his Coumadin a few days before so he could have the pacemaker adjusted. And it was a Sunday morning, and I was there ready to pick him up. He's 83 years old. My mother's 81 years old. She was downstairs in the car, warming up the car, getting ready to go home, like people are. Let's get out of here as quick as we can. A few minutes before they were going to go, the intern decided to bridge with Lovenox, meaning that he had been off his Coumadin a few days, so he needed to get injections of Lovenox for a few days to be sure he's anticoagulated enough till his Coumadin builds back up again. It's an injection. The nurse came in to the room, and I'm the Project Red guy sitting there on Sunday without my white coat. She didn't know who I was. And she said, the intern just decided we're going to do this. And I don't have time to teach you how to do this injection, but here's a cellophane wrapped box. If you go home, there's a DVD in there. If you watch it, it will teach you how to inject yourself. And then he gets in the car, and he said, first thing he turns to me, he says, but we don't even have a DVD player. And sure, what am I supposed to do? And do I have to do this? And I can't inject myself. I've never injected myself ever before. So, it made me realize that, that there are a lot of problems at the time of discharge, and we need to do a much better job of preparing our patients to care for themselves when they go home. And recently, we've been working with our staff in our own hospital, and it's a struggle with our front end staff to show them the things that happen in the hospital that are related to them coming back again. But there are many, many of them. It's easy to say, oh, it's the patients. But it's not all the patients. It's also a lot of things that we can do. And a lot of those things we're going to be talking about today in the next few minutes especially. The design of the day is that we'll spend the first hour or so we'll start with a broad overview and talk about some of the patient safety and policy issues related to transitions in care. A little bit about how we developed Project Red and what it is and how we studied it and the evidence base for it. And then a little bit about the importance of how to get started from the high level with senior leaders and the importance of senior leadership in any culture change in hospitals. And then after that, we'll get a little bit more detailed as the day goes on. Jess and Suzanne will talk about the actual how to deliver Project Red and the details of collecting the information, packaging it into what we call the after hospital care plan, teaching that information, and then a 2-day phone call later to reinforce that information. That's the process of Project Red. And then later we'll talk about each of those steps so that hopefully by the end of the day you'll feel as if you know about the importance of transitions, what Project Red is, and how to actually get started at the sharp end in terms of delivering this process of care. So we've called transitions in care, especially the hospital discharge, the perfect storm of patient safety, in that the hospital discharge is non-standardized and frequently marked with poor quality. That for a long time we didn't have the checklist like the pilots have. The pilot and the co-pilot for every flight sit down to go through the takeoff checklist. Up until Project Red, there was no such thing as a takeoff checklist for hospital discharge. So not only is it non-standardized, but there's a lot of them, and it costs a whole lot of money. And that indeed, there's a lot of data to show that the work that we do in the hospital could be improved, and much of the improvements and adverse events that result from them are related to readmissions. For example, this article shows that the discharge summaries are not readily available. That a lot of the time at the first post-discharge appointment, it's not available. And even at 4 weeks, a lot of the time, it's not available. And having been in that position many times where we don't know what happened to the patient while they were in the hospital, it does not allow you to make optimal decisions. And this discharge summary lacks key components. The hospital course, discharge medications, completed blood tests or lab tests, pending test results, that is, tests that have been done in the hospital, the results are not yet back. And the follow-up plans are often not documented in the hospital. And direct communication hardly ever happens. From the source of care in the hospital to the source of the care in the community, we do a very poor job of that transition. That we're in the silos of the hospital, the community-based organizations, the primary care practices, and connecting those groups is the challenge of the future around ACOs, et cetera. But currently we do not such a great job at any of that. And patients are not prepared at discharge. A study from the Mayo Clinic a few years ago showed that after discharge, a day or so later when they called them, 37% of patients were able to state the purpose of their medications, and 42% were able to state what their diagnosis was. In our data, which is 1,000 patients or so now, when we call them 2 days later, half the patients are making some mistake with the medications that were prescribed at the time of discharge and need to get back on track at that time. And it makes sense. Patients in the hospital are sick, maybe they're febrile, they've gotten narcotics, they've had an operation, they haven't slept well because it's noisy, etc. They're not at the top of their game, plus they have some cognitive impairment to begin with. And we expect, it's taken us years to learn about all these medications and the names, and every medicine has 2 names and all that sort of thing. And then we go in and say, here's your plan, see you later. They want to get out too. And we spend an average of about 8 minutes talking to them about what to do when they go home of this very complex information that we expect them to somehow memorize and go home and to carry out exactly as we expect them to. So it's no surprise that a few days later, half of them are somehow mixing things up. In this study, there were 97 audio tape discharge encounters. The average time of discharge, that's for all people, that's the intern, the attending, the case manager, the nurse, the social worker, etc., was 8 minutes. The teach back hardly ever happened. That is, can you tell me what you're going to be doing when you go home? Patient sits usually as a passive participant. Questions are the answer, but patients don't often ask questions, hardly at all, about what should I do when I go home to take care of myself. And there are lots of redundancy and lots of gaps because it's not standardized in terms of this is what ought to be done. Documentation of pending tests in the discharge summary is also a problem. The discharge summaries mentioned only 16% of pending tests. So not only is this a patient safety issue, but a huge medical legal issue. That there are these tests that have been done that are out there, that who is it that's responsible for following up the results of these tests? And we think that somehow activating the patient to say, give the patient a role in saying, being sure that those tests are followed up can be helpful. In terms of pending tests not followed, in this study, 41% of inpatients discharged with a pending test result. And that could be H. pylori, it could be a biopsy, it could be a test that takes a long time, a whole long list of things. 37% are actionable, 13% were urgent, and 2/3 of the physicians who were responsible for following up those tests were unaware that those tests were there to be followed up. And workups not completed. 25% of patients leaving the hospital require some additional outpatient evaluation that's ordered. More than a third of those in this study were not completed. At our place, we did the same thing. Patients who come in for chest pain evaluation, lots go home to have an outpatient exercise stress test. And so it's not so easy to say, okay, we'll just do the test. You have to make an appointment. And part of Project Red is not just making appointments, but make appointments that people can keep. There's really a very big difference saying, here's your appointment, but working with them to see what day can you come in, what days are good, what day can Uncle Joe drive you in, and all those things. So making an appointment that they can keep, having them get to the hospital. Our place is a big campus, and there's several places exercise tests are done, so they get to the right place. They have to have the test done. The results have to be sent back to the correct community health center, put in the box of the right doctor. The patient has to make another appointment, see that doctor. That test has to be connected to that patient. There has to be a discussion about the results of that test. That process works about half the time at our place. So these are patients with chest pain going home to be worked up afterwards. Half the time it works, and we can do a whole lot better than that. This is data from that we put together, and this is days of the week. This is 90-day post-discharge. This is readmission rate by the day of the week that you're discharged. So guess what has the highest 90-day all-cause readmission rate? If you're discharged on Friday, Saturday, and Sunday, highly statistically more likely to be readmitted to the hospital, giving data that maybe there's something about that discharge process that is actually related to readmission rates. And why not? Because on the weekends, there's covering physicians, there's covering residents, the nursing staff maybe is different than there during the week. The VNA can't see them that day. The pharmacies may or may not be open. They may not be able to get their medicines that day. And a whole long list of things that are different on the weekends than during the day, during the weekdays. So day of the week, being discharged on the weekend is a risk factor for being readmitted to the hospital, at least at our place. And communication barriers. So patients with communication issues have lots more problems. 3 times more likely to have an adverse event in the 30 days after discharge, and 46% had multiple adverse events in the days after discharge. So it's no surprise that all these things are related to adverse events. And Dr. Forrester showed that in Boston, 19% of patients had a post-discharge adverse event within 30 days of discharge. A third were preventable, a third were ameliorable. And he went to Canada and did the same thing and showed that about the same rate, 23% of patients had adverse events in the 30 days after discharge in Canada. So looking at what are some of the causes, it's not so easy to put your finger on a single cause. If it was, we would fix it. But there's lots of issues related to why people come back, having to do with the healthcare system itself, communication between the hospital, the primary care physician, the VNA, et cetera, transmission of the discharge summary, the inpatient team, discussions, inadequate patient education, medication errors, timely follow-up. It's hard we go around the different hospitals around the country, and most hospitals, I would say, do not make it a routine to make a follow-up appointment for patients when they go home from the hospital. It's really fairly astounding. Not surprising, but amazing that patients who are sick enough to be in the hospital can leave the hospital without being followed up for whatever it is that they were in the hospital for. But a lot of hospitals say they come in without a doctor, they go home without a doctor. Not my problem. But also patient issues, of course. Deterioration of known medical problems, alcohol, cultural, language issues, non-adherence, etc. And that nobody says that the 30-day even CMS doesn't say that 30-day all-cause readmission rates should be 0. Okay, right now the readmission rates for Medicare patients are 20%. If we reduce, we'll talk about this in a second, if we reduce it from 20% to 15% over 5 years, that saves Medicare $17 billion. Just that 5% difference. Nobody's saying it should be 1% or 2%, 3%, although it's remarkable around the country how there are many systems that are pushing readmission rates to really fairly remarkably low levels. And then clinician issues, lab tests or errors, the test isn't ordered, not performed, not seen, not acted upon, inappropriate discharges, inappropriate medications, not writing the prescription. In our data, there's a lot of times when patients go home, they get a list, these are the medicines supposed to be on, but the intern forgot to write the prescription, those kinds of things. Somebody came to my office not too long ago, I won't tell you from where, and they said, you got to see this. This is a real patient education form from the hospital that we use. And it was the third page of that NCR paper. Remember that NCR paper, the no carbon required? And if you write really hard, it goes through, to the third page. And the first page goes in the chart, the second page goes someplace else, the third page goes to the patient. And so if you can actually read it, which a lot of times you can't, then even if you could read it, there's things like, 1POTID, that kind of thing. There's Latin. And that, I would submit that this sort of thing, is doing nobody any good. The patients really can't understand that. It doesn't help them to care for themselves when they go home. And there's lots of hospitals around the country now that are trying to get discharge summaries done soon enough where they can give them to the patient. I submit, too, that discharge summary means nothing to patients. That's a good communication tool to the source of ongoing care, but it's not a communication tool that teaches the patient about what to do when they go home to take care of themselves. So there needs to be something else. There needs to be a discharge summary for the providers. There needs to be a health care plan for the patients that's taught to them, and that we've tried to do that. So discharges maybe are the perfect storm of patient safety. There's a lot of them. There's 38 million of them a year. It's not standardized. And they're marked with loose ends, communication issues, poor quality information, poor preparation, fragmentation of care. So it's no surprise that 20%, 1 out of 5 patients over 65 in the United States comes back to the hospital within 30 days. And in this data, Steve Jenks published a few years ago, that of the people who did come back to the hospital, only half of them had a appointment with a physician before they came back to the hospital, indicating that maybe that getting from the discharge to that first appointment might be important in terms of decreasing 30-day readmission rates. So a lot of this has been patient safety research, and it started out because AHRQ had the patient safety portfolio as patient safety research. But then public policy collided, and the administration, last one and the current one, did the math in terms of if you can reduce readmissions from 20 to 15% over a period of years, $17 billion of saving from CMS, and another $17 billion in the private sector in terms of private insurance. So that the Affordable Care Act now is very, very clear on the plan forward relative to readmissions. And that in the Affordable Care Act is Section 3026 here, which is the Community Care Transitions Program, which hospitals now are sort of scrambling around. This is $500 million that the Secretary of Health and Human Services has available to help do pilot projects and demonstration projects around the country. Sort of a complex mechanism where hospitals have to say, this is what our readmission rate is. We think in the next year we can reduce it from 20% to 16%. The accrued savings will be paid by CMS to the hospital as if the rate was 20%. If you reach your goal, then you can set a new target for the next year. It's like game theory almost. And that if you don't reach your goal, you're out. You can't play anymore. So what the idea is that gives hospitals incentives and cash and to be able to develop and implement innovative new programs and to change the way things are done in hospitals to improve the discharge process. So 3026 is available now. They've only had a few cycles, and I think that every hospital that applies will get it. It's a 20-page application. The financial part is a little bit tricky in terms of doing the calculations necessary that they need, but not hard at all. And all hospitals, I think, ought to be able to do that, although I don't know for sure that the VA hospitals are eligible for 3026 or not. And then also recently, there has been value-based purchasing, and that Hospital Compare lists most hospitals around the country who have submitted their data, which is now most of them, that lists 30-day all-cause rehospitalizations for the starter set, which is MI, CHF, and pneumonia. So you can now go online, just Google Hospital Compare, put in Boston Medical Center and Palo Alto VA, I think, or most hospitals, and it'll come up and you can compare readmission rates for those 3 diagnoses at your hospital versus your competitors. And very clearly, as was alluded to earlier, the Affordable Care Act is very clear that payments for discharges within 30 days are going to be paid, those patients are not going to be paid for at the same rates as they currently are now, beginning October 1st, 2012. So hospitals have seen this as a patient safety problem, quality of care problem for a long time. Now there's an enormous financial incentive to decrease 30-day rehospitalizations, and hospitals are, of course, very interested in this. So a few years ago, we asked the question, can improving the discharge process reduce adverse events and unplanned hospital utilization? And sent that grant in, and the grant review panel wrote back and said, that's an interesting question, but what is the discharge process? So we spent then a few years looking in detail at what the discharge process is, hopefully saving other hospitals the work necessary for having to do all that, to identify the commonalities, et cetera, around what's needed for a successful discharge. So we did these kinds of things. A little hard to see, but probabilistic risk assessment, process mapping, failure modes and effects analysis, qualitative analysis, root cause analysis, sort of engineering methodologies applied to medical processes in the hospital. And that we came up with a process map. And that the discharge process, we found, was a whole lot more complicated than what you would normally think. It's not so much, write the order for discharge and they go home. There's a lot more to it than that. For example, are the patients ready for discharge? Now, all these people are involved. There's the medical team, which is the sub-I and the interns and residents and attendings, et cetera, other consultants and behavioral medicine people and physical therapy and nutrition and the patient and the family and all that. So it's a relatively complex set of decisions or conversations that need to happen relative to even a simple question like, are they ready for discharge? And then in terms of the paperwork and the discharge summary, this is the nursing paperwork, this is the physician paperwork, and there's lots of different pieces of information that need to go into these boxes that come from all different places in order to prepare an adequate discharge summary. So it's not so easy to do. And then finally, in terms of patient preparation, the physician team, there's the nursing team, there's the case manager, social worker, and others. And we asked the question, whose job is it, whose job is it to prepare a patient adequately for discharge? So the physicians do some, the nurses do some, the case manager does some, but the answer was nobody really. Nobody has been assigned at our hospital the responsibility of being sure people are prepared when they go home. And when nobody is assigned, when people are in these silos, nobody's assigned to do the job, a job doesn't get done. There's both gaps in what gets taught and there's redundancies in what gets taught. And the complete checklist of what needs to be done doesn't get done completely. So we then brought together key informants from all over our hospital, from all the various sectors of our hospital, from nursing, case management, social worker, physicians, interns, residents, everybody across, for a series of 3 or 4 evening meetings that we bought food and talked about, what is it they want to do. And what we did actually is took our process map and literally cut it up into pieces. So there's like 100 little boxes, and gave it to each group. And we said, okay, this is the process map. These are all the pieces. Take this and redesign the discharge process. Hopefully you can make it simpler and that sort of thing. And at the end of all that process, we had them each stand up and talk about what are the principles that you're trying to get across. What should it be that we're trying to do when we discharge somebody from the hospital? So first, there ought to be explicit delineation of roles and responsibilities. That the discharge process ought not start at the time of discharge, but patient education throughout the hospitalization. Not so easy, because that means there has to be communication between the clinical team, the nurse team, and the others about what it is that needs to be taught. An easy information flow from the outpatient source of care among the hospital team and back to the PCP. And that's also not so easy to do. And changing that turns out to be not so easy. A written discharge plan for the patient, as we mentioned, that is designed in a way that the patient can actually understand it and use it, and their families can understand it and use it. And that the information in the discharge summary or another way needs to be organized and delivered to the source of ongoing care in the community, which means that you have to have a discharge summary. The JCAHO requirements now for discharge summaries is what? 30 days. So that a lot of physicians, private hospitals, I go to these places and they say, discharge summary to the PCP within 24 to 48 hours. Can't happen here. Our doctors discharge patients that come in at the end of the month, they do all their discharge summaries. Number one, we know the quality of the discharge summaries is really bad, because how can you possibly remember all the details? Number two, 30 days later is our metric. So anything that's going to happen has happened at that point. So getting hospitals to actually do discharge summaries in real time using health information technology and everything else is a challenge for many places. So even though these things all seem self-evident, none of them is really easy to do. And you're entering into this process now. And hopefully we'll have a few hints for you later. Waiting until the discharge order is written before beginning the discharge process is error-prone, so it really needs to begin sooner. There are places that are putting up, on the whiteboard in patient's room, discharge tomorrow at 10 a.m. So the whole team knows all that. And can communicate each other about what's been done and what's not been done, and that sort of thing. So efficient and safe hospital discharge is significantly more challenging if discharge personnel work limited hours. So if the case managers come in at from 9 to 3, a lot of discharges at our places, the average time of discharge is after 3 o'clock. So that you're missing a lot of people. So that's not so easy to change schedules or have other people do it, or have people there all the time who are able to do it. It's hard. All patients have access to the discharge information in their language and at their health literacy level. When we made our after hospital care plan, which I'll show you in a few minutes, we said we had health literacy people, we had graphic designers. I said, think comic book, really, so that people can understand it as best they can. Those at risk have the discharge plan reinforced after discharge. That is part of Project Red. So that 2 days after discharge, they get a phone call. And the phone call is not a social call. It's not, hey, how you doing? Hope everything's okay. Hope you enjoyed your stay in the hospital. It's go get your medicines, bring them to the phone. And later we'll talk for quite a bit about the content of that call. Let's go through them. That's where we find out that half the people are haven't got the prescription, didn't bring it to the pharmacy, didn't get it filled, didn't take it home, aren't taking it, decided not to take it, had an adverse event, etc. And all those things happen a lot. And discharge processes need to be benchmarked, measured, and subject to continuous quality improvement programs so that we know what % of patients are getting all the various things. And we have a lecture later today about exactly that, what we think some of the key benchmarks are that are process measures for a good quality discharge program at a hospital. And then the big one, which is 30-day all-cause readmissions, which hospitals are going to get paid for or actually not paid for. So then, from the principles of what ought to happen at the time of hospital discharge, we came up with the RED checklist. And I got a call one day from the National Quality Forum, and I think some federal law was broken here, because they actually, what happens is they read one of our grants, one of the grant review panel. So one of the reviewers called, you know a lot about the discharge, so can you write the NQF safe practice, which is. So we did that, and so the National Quality Forum safe practice is actually Project Red, except for one thing, which is not part of Project Red. in that the National Quality Forum, once they disseminated and asked for comments from around the country, added to close the loop. When you send the information to the PCP, you need to get information back from the PCP, confirmation that they received it. We thought about that, but we said there's no way at our hospital that's ever going to work. That's like beyond what we think is even possible. But that's part of the safe practice, that you close the loop in terms of sending information back to the community. Remember, the red checklist are these things. So make an appointment for the follow-up medical appointments and post-discharge lab tests. Not just the appointments, but appointments that people can keep. And later on, we'll talk about how that actually happens. And there's a discussion about what days can you go over the next 2 weeks and that kind of thing. A plan for follow-up of results from the lab tests or studies that are pending at discharge. So first you need to identify what are those tests. They need to be put somewhere. We put it on what we call the after-hospital care plan. Tell the patient about it. Say, please be sure to raise this with your physician and then send that to the source of ongoing care so that the odds of it being followed up are greater. Organize post-discharge outpatient services and medical equipment, the beds and all those things that need to be done. Identify the correct medicines, because these are things that get people back. If they're going home on oxygen, the oxygen is not ready yet, they come back. If they can't get their INR test in 2 days, they come back to the emergency room. That's the biggest cause, actually, of coming back to the hospital. If the CPAP machine somehow is delayed a few days, then they end up back in the hospital, etc. Identify the correct medicines and a plan for the patient to obtain and take them. So this med-rec issue is also a big issue at a lot of hospitals, and everybody's struggling with how do you actually do med-rec correctly and get it and then teach it to the patient. Reconcile the discharge plan with national guidelines. What that means is we know that a lot of patients are not being treated according to national guidelines. So why not at discharge use that as an opportunity to check to see if you have a diagnosis of congestive heart failure, are you on an ACE inhibitor? Did you have an echocardiogram? And all those sorts of things. And that the discharge advocates in our system have a list for some diagnoses, the important diagnoses. And then they go to the team and say, gee, there's no ACE inhibitor. And a lot of times there's a reason, but a lot of times there's not. It's just that we haven't done it. So it's a double check on meeting national guidelines, which there's a lot of pay for performance funds for hospitals on the line when those things aren't done. 6, teach a written discharge plan that the patient can understand. 7, educate the patient about his or her diagnosis. I'm not sure, actually, and we debated about this. If patients know the diagnosis, is there some mechanism at which they won't come back to the hospital? I don't know. But I just think fundamentally people ought to know what they were in the hospital for. And that study that shows that half the patients don't even know what they're in the hospital for. And that's been confirmed in other places. They ought to know what they're in the hospital for. So that's part of it. Assess the degree of the patient's understanding of the plan. This is a really important one. So later on we'll talk about teach back, but testing the competency. Do people actually understand it? It's one thing to say, here's your med list, or here's your after hospital care plan. Another thing to teach it. It's yet another thing to say that at the end of teaching the medicines, you say, gee, this is an open book test. You can look, you don't have to memorize it. Tell me how many times a day you take lisinopril. They should be able to do that. If they can't do that, there's a problem. And another plan needs to be put in place. Bring the family in or something else that needs to be done. But we don't even assess. We rarely do we do that. Review with the patient what to do if a problem arises. Now, that's something that everybody going home from the hospital ought to know. 1, what's a problem? Number 2, what do you do if it happens? The thing the patients tell us they worry about the most when they go home from the hospital is we can't reach anybody when we go home. Nobody returns our calls. And what do? They go back to the emergency room. You go back to the emergency room, you're halfway in the hospital. So, that's true, huh? But wouldn't it be better if somebody called back and said, take 20 more Lasix, or gee, this is how you're supposed to take that medicine, or this is how you use the CPAP machine. Expedite transmission of the discharge summary to clinicians accepting care of the patient within 48 hours so that they know and that you can transfer care to them. They have all the information so that when the patient calls them with this problem, they know what's been done so they can make a decision about what to do for them. And then we think providing telephone reinforcement of the discharge plan to reinforce all those things, to identify some adverse events, identify holes in the plan, identify what the patient isn't doing right, and to fix those problems. So, so we operationalized the re-engineered discharge program using what we call the after-hospital care plan. I'll show you what that looks like in a second. And in our program, it's taught by a discharge educator, because in our research project, we had research funds so that we trained nurses to do Project Red according to the protocol. Now, in our ARC sort of rollout project, where we're working with 10 hospitals around the country, hospitals are choosing lots of different ways of doing this. We don't know the right way. We know the way we did it seemed to work. But is hiring a new cadre of worker called the discharge educator what needs to happen across the country? I don't think so. I think there's lots of people in hospitals. If you can really redesign the jobs, et cetera, of people do in the hospital, a lot of the discharge work can be done by current people. But in our research project, we had, because it was a research project, we had discharge educators do that, which we called the discharge advocates. And then the follow-up phone call, which in our system was done by a pharmacist, a PharmD, made the phone calls. And the after-hospital care plan is a patient-centered instruction booklet. It was designed to reach patients with low health literacy and individualized for each patient and for the hospital. So it's tailored to their information. It's not something that's printed out. Obviously, everybody gets the same thing. It's tailored to their medicines, their physician, their appointments, their allergies, all that sort of thing. So this is what it looks like. This is what we use to teach patients in the hospital. So it has the patient's name. Guess what? It used to be called the discharge plan. Then in our focus group, patients told us discharge. It's like runny noses or that kind of thing. So even health literacy to that level, people get confused about that. And then the date they're going home, and then a picture of their doctor, because a lot of people are going to places where they're going to see them for the first time. And if it's not so hard, you have a list of the PCPs in your system. Everybody has an ID, so we just took those pictures from the IDs and easily put them on the plan. And then the person who's going to be calling them in a couple of days, who they sometimes have met in the hospital. And then the medications, we thought long and hard about, sort of the Teach Me 3 technique, which is, why am I taking it? What's the name of it? All the names, both names. How much do I take? And how do I take this medicine? There's not much up there about pathophysiology, not much about mechanism of action, but you go to a lot of places, you get the handout, or these self-printed things from all these companies that do this patient education stuff. And it's mechanism. Nobody cares about the mechanism of action. Nobody cares about how these things work or the pathophysiology of it. And then a lot of icons, like the morning we put a sun. So take these medicines for this reason in the morning. At the beginning, we used to take photographs and put them in there of the pills. But then we learned really quickly that people go to the pharmacy when they get it refilled or something, that often the generics look slightly different than what the medicines look like. So we didn't want to cause more, so we stopped doing that. And then morning, and then at noontime you take those medicines. And then in the evening you take this, at bedtime you take that. And then PRN medicines are here. And then there's a section about appointments. And here you can see they're color-coded, pink and green and orange, yellow. And this is the primary care physician. It's Tuesday, October 24th, where it is and all that sort of stuff. And if you need to call for a change appointment, it's down here. And here's your rheumatologist, here's your cardiologist. But also the day the VNA is going to go there, the day your INR test is going to be done, the day that you have to go in for your stress test, the day that your hospital bed's going to be delivered. All those are our appointments, are put it in the after-hospital care plan. And they're color-coordinated to a calendar, which we give them a magnet. You can get some magnets. We'll give you little Project Red stickers. You put a little Project Red sticker on it, put the magnet on it. And people usually open it up to this page, put it on the fridge. And people like it. If there's any other reason to do this, it's patient satisfaction. People, strange as it may sound, people really like to know how to take care of themselves when they go home from the hospital. It's shocking, really. And the families really like it too, because they go to the elderly parents' home on the refrigerator and the magnet with, here are the medicines very clearly identified. Here's the next 30 days of what they need to do. So the families then feel empowered and able to help them, which is what they want to do. But if they don't know what to do, it's hard to do that. And then there's a section in here which is about it's what we call it the patient activation page, so that they can write down questions and things like that to bring to their primary care provider in that appointment that comes up later. And then we are working on diagnosis pages, and there's a lot of patient education materials out there on the web, and that we've designed some ourselves, with that are clear with as few words as possible, and describes things to the level of what people sort of need to know, and tells them what to do and what a problem is and that sort of thing. So that's the after hospital care plan. So that's how we operationalize Project Red, so that the nurses collect information, produce the after hospital care plan, teach the after hospital care plan, and then a phone call later. So we said, if we did Project Red, will we lower hospital utilization, improve readiness for discharge, and increase primary care physician follow-up? Those were our hypotheses in a randomized controlled trial, which enrolled 750 patients, 375 in the Red intervention group, 375 in the usual care group, and the outcomes were 30-day readmissions by a phone call. We called all the patients and looked at their electronic medical records later. So how well were we able to deliver the intervention? This is important in the sense that even under research conditions, there are times when you just can't do what you hope to do. People look at this and say there's a lot of sort of face validity to our study because it's realistic in the sense that we were able to make appointment 94% of the time. Why? Because sometimes they come on Saturday, sometimes the discharge advocate wasn't able to meet with them or get it done or something. The after hospital care plan was given to the patient 83% of the time for the same reasons. The discharge summary faxed to the PCP 91% of the time, and the pharmacist was able to reach 62% of the patients 2 or 3 days later. So that was the intervention. So what did we find? We found that the readmission rates here at the bottom, in the usual care group, there were 76, which is a 20% rate, and there were 55 in the intervention group. The ED visits went from 90 to 61, and our a priori hypothesis was that hospital utilization, which is the sum of those two things, went from 166 to 116. And that over 30 days, the intervention group was 30% less than the usual care group, saving lots of money because if you can decrease the amount of money on from usual care to intervention for hospital visits, if there are fewer hospital visits, you save money. If there are fewer ED visits, you save money, but not as much. There were more PCP visits, so that actually cost a little bit more. And then the total cost per subject is here, and the difference is $412 per patient enrolled, and the number needed to treat of 7, meaning that for every 7 patients who received Project Red, 1 of them did not come back to the hospital. And in RCT world, a number NNT of 7 is a really low number. So we believe that the Red program works, and that the hospital discharge, for all the reasons that we talked about, is low-hanging fruit for improvement. That Red is a National Quality Forum safe practice, that Red can be delivered using the after hospital care plan tool, that it can decrease hospital use. There's a 30% overall reduction. The number needed to treat is 7.3 and saves $412 per patient for every single patient admitted to the hospital. So now there is a lot of, for the reasons that we talked about in terms of national policy, there's a lot of interest in working with hospitals on in helping them to implement programs to decrease readmission rates. And that from AHRQ's point of view, AHRQ has given a contract to JCR, which is a Joint Commission Resources, which is the for-profit arm of Joint Commission, which does hospital accreditation, et cetera, to implement Project Red in 250 hospitals around the country. And apparently we heard that 246 signed up like in the first week. So there's a lot of activity around hospitals looking for ways to improve their hospital discharge process. And then the contract we have now is a dissemination contract with RED to do the kinds of things that we're doing now with 10 hospitals around the country. Because what we want to find out is, how is it that hospitals take this information and then adapt it to their personal use? What patients do they use it on? Who does the discharge advocate role? Who does the phone call role? How much of the discharge summaries can be done at the time of discharge, etc. So we're studying the process of implementation. We're studying the process of changing the culture of care in hospitals. It's one thing to do a randomized controlled trial. Another thing to say, can hospitals do this on a regular basis to get the results that you hope to get? And how to impact the culture of care? And does it work in the real world? And how can we improve efficiencies so that we're not adding costs to the system? So we talked a little bit about the Safe Transitions Program, which is a CMS QIO, that's the Quality Improvement Organizations around the country. They gave them large contracts to study safe transitions. Many of them used Project RED. And now CMS has the Community-Based Care Transitions Program, which is 3026, which is what we talked about before, which requires that hospitals use, they define it as hospital-based transitions programs. And there's Project RED and there's Project Boost. So Project Boost was developed by Greg Williams and Jeff Greenwald. Jeff Greenwald worked for us when we developed Project RED, then went to Society of Hospital Medicine. So they're very similar in terms of how they do it. And they did a good job of setting up implementation protocols and that sort of thing for hospitals. And then there's post-discharge programs. And you maybe have heard of Eric Coleman's work in Colorado, the Care Transitions Program, Mary Naylor's program at Pennsylvania. So between RED, Coleman, Naylor are the evidence-based programs that CMS is pushing. RED in the hospital, Care Transitions, and Mary Naylor's program out of the hospital. And Don Berwick said recently that there will be no more randomized controlled trials in transitions of care because we know enough. And that's a Berwickian kind of statement. Now we need to do continuous quality improvement about how to do these things. We know, all this stuff makes sense, that we need to prepare patients better when they leave the hospital. There's a lot of positive results in terms of patient satisfaction and readmissions, and that now it's a matter of how to do it exactly. So, because there's been so much sort of interest and that we get lots of phone calls and emails and that sort of thing, that we work through the Office of Technology Transfer at Boston University to work with engineered care. Marcus walked in during it. Marcus, want to raise your hand? So Marcus will be talking a little bit later. And engineered care has done a great thing, which is to take our research software program that the nurses collect the information, entered into the software, print the after-hospital care plan. So engineered care has taken our research software and really developed it very nicely so it's usable now in hospitals. And that it is available for hospitals to use for efficiency purposes if they choose to do it that way. And later on, I think after lunch, Marcus will be talking about how that software works, right? And then just a word about, we talked about, we've done quite a lot of work in health information technology, and maybe you've heard about it. That's why I'm mentioning it now. And that if you look at our web, if you just Google Project RED, you can see our website, and there's a lot on there about Louise. And I'm not going to it's hard to see, but Louise is on this computer. This is Kathleen Sebelius, Secretary of Health and Human Services, and this is Carolyn Clancy, who's the head of AHRQ. And this was Secretary Sebelius' first visit to AHRQ. And they had kind of show and tell, and they showed Louise. And Louise is our animated, computerized character. This is Silicon Valley, right? So people like this. So maybe we should talk about it. If everybody's interested, we could talk a lot, because we spent 5 years and lots of money developing Louise. So Louise, the information from the software goes to print the after-hospital care plan. It can also go to Louise, and Louise is on a kiosk with a weighted bottom. It can go into the room under the bed where the arm goes over on a touchscreen, and Louise, with empathy, teaches the after-hospital care plan. And that we're doing studies now about using this information technology system to save nursing time, because we knew the pushback would be, this is really interesting, but how can nurses possibly spend more time than what we currently have? So That's not part of what we're talking about today, but we could talk a very long time about that, and someday maybe we'll get a chance to show that to you. So in the next few minutes, I just want to talk about sort of how to get started at a hospital or within a hospital system. And that we have had some experience now with working with both hospitals and hospital systems. And it's very clear that the role of senior hospital leaders in making change within the hospitals is absolutely critical. And that the organizational model that we think about is active top leadership commitment, multidisciplinary evidence-based clinical process redesign teams, and links to senior management structures and processes will improve the outcomes. So this is the organizational transformation model. So active top leadership, sort of more front-end process redesign teams are both necessary for change. So the hospital discharge redesign is necessary, and we find very much so for Project Red, the support of senior leaders in the hospital, an implementation team that engages frontline staff. David left, but it sounds like David is in charge of the implementation team here. And that, and necessary for both to redesign the work processes somehow so that things are done slightly different than what they were done before, and then monitor progress. So these, I think, are the four steps or areas that hospitals need to focus on. So in terms of the senior leadership role, what are some of the key factors that are helpful in terms of implementation? One is to align with the organization's strategies and priorities. That's the role of senior leadership, to be sure that hospital readmission policies and hospital readmission reduction and increased patient satisfaction, et cetera, is in alignment with what the hospital wants to do. And then clearly to set the vision and then communicate the commitment and the goal to the frontline staff. In some places, we have had people who set up newsletters and talk about some of the information we're talking about today, so people are educated about what the issues are relative to readmission and what the importance are later. And then grand rounds for the physician staff, M&M and root cause analyses around patients who are frequently admitted to the hospital to study those people, because you can learn a lot about readmissions from those people who come back frequently, and then various emails. At one of the hospitals, a big hospital, a very big hospital system in the Midwest with 14 hospitals, the person who, the senior leader, is the head of the health plan that's associated with 14 hospitals of a university system. And he very much set the organization's goals at reducing readmissions. And we started with 2 hospitals. We wanted to do 1. He said, let's do 2. So we did it within 2 hospitals. And now they have quite a lot of data. This is 3 or 4 years later. And what they found is that all across the board, for private payers, for Medicare, for Medicaid, and especially for dual eligible types, it seems as if the readmission rates for those groups and for Medicare patients over 65 dropped dramatically using Project Red especially. But for private insurers, both the intervention and the control group went down from 11 or 12% to 6 or 7%, both, by paying attention to the problem. And I think there's really a lesson in that we don't say, no one would say that if your readmission rate is 8, can you lower it to 6 or 5 or 4 with Project Red? I don't know. We didn't do that. But I think by senior leadership paying attention to the problem, and he would go to grand rounds, he would talk to all the leaders in the hospital and talk to nurses and all that. At the end of his presentations, he would say, if you have a problem with this, I will set up time personally to talk to you about why this is such an important thing for our hospital. Now, 2 or 3 years later, he says that this effort, overall effort, which includes Project Red, but I think a lot of it's him, making the change at his hospital, has saved many millions of dollars for his organization. They're going to roll it out to all 12 hospitals in this big university system. So the importance of personal investment in this, just drives everything better. And that the Project Red is a list of things that are very important, but it's the sort of the leadership that makes it happen. And then also provide resources and staff and figure out how to do that exactly. Who does the phone call? Can it be done by the nurses on the ward who know the patient, and then when they go home a day or two later, do they make the phone call, or do you need a pharmacist to do the phone call, et cetera? And interestingly, we've also been talking about CVS. Can I talk about CVS? That CVS, the company, the pharmacy, called us and said, of course, people like us because we use pharmacists. Pharmacists like us a lot because we had a pharmacist do the 2-day phone call, which somehow they think is really, really great for pharmacies. So CVS called us and said, we would like you to enroll some patients in your hospital. If they use CVS Pharmacy, we want you to then send them to CVS, and our pharmacists will do the med rec and be sure everything's okay and do the phone call, basically, maybe in person or by phone. And that the senior people at CVS are saying this is going to move CVS from being a retail pharmacy to being pharmacy consultants for post-discharge. So it's a really big deal for companies like that to get involved in being sure people are taking the right medicines when they go home. So senior leadership is to create the implementation team, integrate it across organizational boundaries, because this is across the board. And that at our hospital now, we have a geographical service where our service is. And I'm realizing how hard it is that there's the case manager, the nurse educator, the physical therapist, the residents, the nurses, and getting them to work together as a team, because discharge preparation is teamwork. And breaking down those barriers between all those groups and getting them to work together towards a common goal is really hard to do. And I really would like to do a project called Reengineering the Hospital Ward, because it really needs to be done. We really need to think about all those people that are there and what everybody is doing. Hardly any communication. Everybody's doing their stuff. Not much communication. And what is the goal that they're working towards? There's no common goal that's owned by that group. So we're really working on that. Suzanne is going to do teams training. We're going to get everybody together and do teams training and try to get them to focus on a common goal that we all share, etc. A very big deal is getting IT on board, so that if you're going to use the software we have or develop your own software, however you do it, that it makes you can print the after hospital care plans and create every one freehand, but it's not efficient. It's probably not going to work. So that having some way to have the software print the after hospital care plan, but more importantly, have some software product that connects to your IT system, so as much flows as necessary into that software, so there's not redundant data entry, is a key piece of efficiency. And IT is the barrier at a lot of places. It's not hard to do at all. It's just a matter of getting it on their agenda. And then hold people accountable, report and monitor the progress, and recognize and reward success, which are leadership skills in general. So that's the leadership team. What about the implementation team? So the implementation team, which is David's job, is to recruit a collaborative interdisciplinary team, identify the process owners and the change champions, who are the people at your hospital who are going to really make this work. In our team at home, there's the Irene. What's Irene's title? She's the case manager for the service. But her metric is the time of discharge. The hospital somehow, when they talk to case managers, I don't know if it's the same at your hospital, but they try to get people discharged early in the day, and she's responsible for that metric. So that she wants us, as a team, to take on the time of discharge, because of course the residents and the attendant, everybody has to contribute to. For her to be successful, everybody has to contribute to that. But she's a real change champion. She really wants to get these things done. Communicate widely, energize the staff, and get buy-in amongst all the various people that will be working to implement the project. Promote staff engagement at all levels, including all those people that I just mentioned. In fact, our team's training is going to include the housekeeping, it's going to include nutrition, Because when you look at patient satisfaction, which is a big outcome of ours too, then nutrition makes a very big difference. And housekeeping too. If the room is dirty, if there's alcohol wipes with blood drops on them and stuff like that, that makes a very big difference in terms of your HEDIS measures and your patient satisfaction measures, Press Ganey scores, and all that kind of thing. Promote staff engagement at all levels. Build skills to support and sustain improvement. Meaning, doing training sessions on how to teach the after hospital care plan, doing training sessions on how to do teach back, doing training sessions on how to do the 2-day phone call. Troubleshoot as it's rolled out, because there'll be some issues that come up that need to be fixed. Monitor the progress, provide feedback, and then sustainability, which is what it's all about. Anybody can do it for a short period of time, but doing it for a long period of time is harder. So exactly how to get started, more specifically, David, this is for you. This is your list. So make a clear and decisive statement and get buy-in. Appoint the team leader. I don't know if it is or not, but constitute and implement the implementation team. Analyze your current discharge processes and rehospitalization rates. And some hospitals are not very good at this. Some are very sophisticated at that. There's one hospital I went to that could go click, and hospital 30-day all-cause readmission rate by floor, by attending, by group, by diagnosis, by discharge time, all these sorts of things. So it's very sophisticated analysis. Most places can't do that, including us. Number 5, establish the goals. What is the target rehospitalization rate? What is your rate now, and where do you want to go? And what is it that you need to do it? And what are the appropriate interventions necessary to get to where you want to go? And I would say that if your rate, as I alluded to before, if you go on the CMS website now to 3026, the hospitals that are eligible to apply are those by themselves are those in the bottom 25% of rehospitalization rates. And those hospitals can apply directly. If you're not one of the worst 25 hospitals, then you have to partner with a community-based organization to apply for 3026 funds. So all hospitals can apply, but those in the bottom 25% can apply by themselves. So those in the bottom 25% have rates that are well above 20%. 20% is the average, so it's around that mean. So that some are very high readmission rates. So things like Project Red, there's no question if you're in the bottom 25%, it will lower your readmission rate significantly. Eric Coleman's program, Mary Naylor's program, will lower those programs significantly. If your readmission rate now is 8%, we don't know exactly how to do that. I would say that you need to think about in terms of implementation. People say, is Red and Coleman compatible? The answer is yes, it is, because Red is in the hospital. It's relatively low tech, it's relatively simple, and people like to know this kind of information that you're giving them. And I think everybody should be given an after-hospital care plan. Why wouldn't we want to do that? If for no other reason, satisfaction goes up and readmission rate and ED visits go down. But then for high-risk patients, and we're not going to have time today to talk about risk scoring systems. How do you identify patients most likely to be readmitted to the hospital? It's another whole topic that we could maybe talk about in the breaks and things like that. But for high-risk patients, then they need Coleman and Naylor, which are more resource-intensive, more people-intensive, post-discharge phone calls and home visits and things like that, is my view of how those things fit together. But knowing your rehospitalization rate will tell you kind of what it is that you need. Another major point at the beginning as we get started today is that if we were going to do Project Red today, and maybe we still should do this, I would add a 12th component, okay? And that 12th component is activating the primary care practice, okay? So that what you can do there's only so much you can do within the hospital to affect your readmission rate. So much of it is post-discharge. And that there are studies now where people work with the practices, the high volume practices to hospitals, where a nurse usually has a meeting each week to talk about their practice patients who are in the hospital, calls the patient in the hospital, connects to the team, gets the information, tells the patient, Dr. Jones will see you 2 days from now, be sure they can see them right away, and is the connection point from the hospital through the black box to when they get into the primary care. Those programs have been shown to decrease readmissions really dramatically. So both there's the hospital component, there's the PCP practice-based component, and then there's the community-based organization VNA component, which is Coleman and Naylor. And all those together are, I think, very powerful. And then establish the timeline. When do you want to do the kickoff, like today maybe? When do you want to do the training of people? When do you want to begin the program? What diagnoses, what floors, what wards, what people, who's going to do, the discharge summary is going to be done, who's going to do the phone calls, et cetera, et cetera. Identify the target patient population. Who's going to fulfill the role of the discharge educator? Is it somebody you already have, or are you going to hire new people? And who's going to do the follow-up phone calls? Step 10, determine how to train the DEs and the phone call staff. Decide how to generate the after-hospital care plan. Adapt the transitions of care for low health literacy and limited English proficiency patients. So get it all going, and then know that, like the data we showed earlier, people with low English proficiency and low health literacy are at risk for readmission greater than the general population. So not doing discharge preparation for that group of patients, you're missing an opportunity. And decide how and what to measure in terms of both process measures and big outcome measures, both readmissions and costs to the hospital, costs to the plan, and then continuously feed that back to the sharp end so that people will continue to improve. So that's the end of the first session now. So congratulations on addressing readmissions as a very important clinical and policy and financial issue. And we look forward to working with you for the rest of the day and in the future too. So thanks very much.
I wondered in the group of patients who did successfully receive their follow-up phone call from the pharmacist, what were the outcomes with respect to readmission for that subgroup?
Yeah, that's a good question. Yeah.
Somehow you could facilitate that aspect of it.
Right. We think that the phone calls are a really important part. When we looked at those that received the phone call, now that was only the intervention group. So that if you received a phone call versus not received a phone call within the intervention group, you were highly less likely to be readmitted to the hospital. Now, because that's not randomized, is there something different about patients who have phones, answer the phone, that sort of thing? But there's no question that those who receive the phone call are much less likely to be readmitted to the hospital. And later we'll talk. There's a session on what to do with that phone call, and as I mentioned, it's a action phone call, and that part of it is bring your medicines to the phones. Let's go through them one by one. Did you? And I have a list here of what you're supposed to be taking. Did you get the prescription? Did you fill it? Are you taking it? Any problems? That sort of thing. And if not, fix it. So that we have a list of, maybe I think it's in that lecture, of what kinds of actions and what percent of the time the person who makes that phone call actually has to do something, like call the PCP, call the hospital-based team to clarify what they're supposed to be doing, that sort of thing.
So what's the general experience of the behavior of the long-term patients? Get better and better and better, and then it comes down to some kind of equilibrium level, or not getting better. So what's the general experience?
For the readmission rates, you mean? Yeah. Yeah, I think we've seen presentations now from especially hospitals that are part of networks where the plans, the insurance plans and the hospitals are the same organization. So maybe that's an accountable care organization where the financial incentives are for patients. If patients don't go to the hospital, then the system wins. The hospital may not win. And that for years now, and people don't like to hear this, But the financial incentive for hospitals has been admit as many as you can, heads on beds, discharge them as quickly as you can because of DRGs, and readmit them as quickly as you can. That's the financial incentive. Now, of course, nobody does that on purpose, but I think at some level, because the financial incentive is there was never been any disincentive to readmit people back. Because there's no disincentive, people didn't pay much attention to this whole area. Now people are. Today, if you're a hospital that's operating on the margins and your readmission rate goes from 20% per month to 15% per month, you're going to have empty beds. And it's going to affect your bottom. And people are still getting paid heads on beds now. So a lot of hospitals tell us what to do. We're going to get it ready to go. But we don't want our readmission rate to go down today. But next year in the fall, it's going to be important. And then progressively over 5 years, the hit gets higher to hospitals. But even then, hospitals, the worst case for hospitals is that if they stay at 20%, and that they don't get paid for those patients. That's the worst case. So the patients are in the hospital. There's a lot of resources expended on those admissions, and they don't get. If you decrease the readmission rate, then you're not going to get paid for those patients either. You're just not expending the expense on those patients. So the overall idea from what the federal program is to decrease the number of admissions to hospitals. That's really fundamentally what it is. And so that if you are a plan who patients are insured, if patients are not going to the hospital, the plan wins. The hospital might lose a little bit, but the plan wins. And people who are working together as a team win in a big way. And those are the places that have driven their readmission rates down to really low levels through three things. It's Project Red in the hospital. It's working with their PCPs to be available and to do what's necessary post-discharge. And it's activating the community-based organizations, the VNAs, et cetera, to do the Coleman-Naylor model. All those three things together are synergistic together to drive things down low. There are places around the country who have reported 4, 5, 6% readmission rates. I can't tell you what the right number is. Nobody knows the right number. We have data actually for congestive heart failure showing that that the number might not be 5% or 6%, but it's probably not 20 either. I'm guessing 12. But I don't know. Yeah. Yeah. In the frequent flyer group, you mean? Well, in terms of for the frequent flyers. Yeah. Yeah. If I understand it right, so yeah, when we added in our analysis, when we added an interaction term into the analysis, the frequent flyers benefited from Project Red more than the average patient did. That was really the only group. When you look at what are the predictors of readmission, frequent flyer, depending how you define it, we define it as 2, I think, in the last 6 months. That it's off the scale in everybody's database as the most important thing in terms of predicting who's going to come back. Past performance predicts future performance. And if you come back, if you're whatever it is about your circumstances that you use the hospital as your place for healthcare, then you're going to use that in the future. But there's a lot of other, the classic predictors of readmission are frequent flyer status, length of stay. Age is really important too. Maybe the second most important thing. Over 65, of course, you're older and sicker, et cetera, will come back to the hospital. And some indicator of comorbidities, more comorbidities there. So those are the classic things, predictors, characteristics based upon administrative data that have been in literature for some time. We, and Suzanne particularly, have looked at our data, looking at secondary data analyses, and have added to that a variety of different things. The most important of that is that when we enroll patients in our studies, we administer the PHQ-9, which is a screening tool for depressive symptoms. So those patients who screen positive for the PHQ-9 are highly likely to be readmitted to the hospital. That's new in the literature and makes a whole lot of sense, we believe, for a lot of different reasons that, people who are depressed, it doesn't matter if they're depressed and then get sick, or if they get sick and it doesn't matter. They are still at risk for coming back to the hospital, so that maybe some intervention now. So we're hoping, if we have a new grant out, that we're going to only enroll people who screen positive for depressive symptoms, randomize them into Project RED versus Project RED plus a post-discharge mental health intervention. So if the Moore Foundation is interested in supporting that, we'd be really excited about that. Because I think that's an important project to do, and I think that because the readmission rates are sky high, and we won't even need that many patients because it'll be easy to show, a readmission rate of 40-something%, being decreased to 20-something% by an outpatient mental health intervention. So that's one thing. So depression is one. When we screen for health literacy using a variety of different tools, and people at low health literacy are more likely to come back to the hospital. There's another instrument called the PAM, which is the patient activation measure. So people who have more confidence and abilities and self-efficacy and that sort of thing, then they're more likely to not come back to the hospital. And in our place, this doesn't pan out every place, but in our safety net hospital, men are more likely to be readmitted. So men, we find at Boston Medical Center, which is the old Boston City Hospital, are really bad at healthcare. Really bad. And that in our data is very clear that men, when they're in the hospital, we ask them some questions about, how prepared are you for discharge? How well do you understand your medications? How well do you understand your appointments? Men statistically are less than women in understanding all that stuff. Men don't make have fewer PCPs, make fewer PCP visits, and go to the emergency room a lot more and get readmitted a lot more. So in our system, which maybe is different than some other systems, is men are bad at all that. So those are some of the new wave of risk predictors that are out there. That kind of clinical data. I didn't get the memo on the red thing. I could have done that. I got a really good red tie. Yeah.
Maybe the Kaisers or the VAs of the world have more incentive to be paying attention to perform and be better at things.
Right.
What experience has Red had in those places?
Yeah. Well, Kaiser, Intermountain Health, Group Health, Mayo Clinic, those places have very low readmission rates. They like Red. They're using it in a lot of places because it's for the patient satisfaction side of things. And because there's other benefits, so that if your rate is 6 or 7%, which it is at some Kaiser hospitals, it's probably not going to be much lower. But to do, but for pay for performance, you hit all the measures relative to hospital discharge procedures that need to do. You document what was done. Patients are much happier when they go home. There's reasons to do that. So yeah. So. I'm not sure. I don't know that we know that for sure. Yeah.
Second question is, in your first study, the 300 or so patients that you looked at and showed your 30% reduction, that was what population? That's medicine, surgery, psych?
Yeah, good question. It was a general medical service, so medical patients.
Okay.
Yeah. So does this work on surgical patients, orthopedic patients, psychiatric patients? We don't know. There are places around now that are doing it in all those areas.
And we don't know yet how it differed between those populations?
Well, we'll have to look. I should put a slide on some of the outcomes. There's a slide set on the CMS website from the Safe Transitions QIO group from the Nebraska VA that says that's titled How We Implemented Project RED, and shows a lot of their data at a VA hospital. There's data from University of Pittsburgh Medical Center showing dramatic results. There's good data, I'm told, that's coming out in JAMA from Brownsville, Texas, or near Brownsville, Texas. This was the Texas QIO. So, but none of them generally start out at low rates. Those are high rate places that can be decreased. Of course, the lower the hanging fruit, the easier it is to show a reduction.
Last question is, you in your slide, I think it was $412 or something like that.
Yeah.
Per patient in terms of savings and outcomes cost.
Yeah.
Is that VICE implementation costs, or that was in outcomes
that was
only?
that was not including implementation costs. Yeah.
And what have you learned?
So what we know is that if it takes a nurse an hour to do this, and they get paid $100 an hour, then you save $312 per patient. It doesn't, and nurses don't get $100 an hour, I don't think. I don't know. And it probably doesn't take them an hour to do this process. So that's not implementation costs. It's a little hard for us. We didn't. In our paper, we say that explicitly, that because it's a little hard in a research setting to know what's research for what's real cost of the program. Kind of what we're looking for now is to see what in the real world, what's it really cost. Because there are different ways of doing it that I think that will be cheaper. I think in the back first. You don't have red on notes. Yes, Scarf.
The question I have is about how, it's a little bit of follow-up on Paul, on how the VA as a more capitated system may differ in important ways relative to private sector models. And I should know this, but I don't. I mean, VA Palo Alto is now listed under Hospital Compare. Our stats on the three measures are a little bit better than average. But am I right that only looks at readmissions to our facility, not to other hospitals? The reason, let me explain why I'm asking that. Yeah. Because one of the unique things is the high-risk patients are the ones 65 or over. The vast majority are duly eligible under Medicare. And we increasingly across VA serve a huge catchment area.
Yeah.
So my concern is that we're not catching those that, for example, are out in the hinterlands of Sonoma or Stockton who are admitted locally. And so we may have some false reassurance by our stats are slightly better on Hospital Compare than the mean values.
Right.
But I wonder if we might actually be a little bit worse if you in some way took that into account.
Yeah. Yeah, my understanding is that for Hospital Compare, it's voluntary and that hospitals submit that information.
So that would make sense because the IPEC data, which is the VA way, is really quite similar.
Yeah.
And it's a real common problem that I've looked at in trying to understand for elders that are duly eligible.
Right.
There's this, we are invisible to each other, even though we're the same federal government. The Medicare database and the VA database just don't see each other. Yeah. So I think one of the unrecognized problems in the VA, and if we're trying to, the VA is admirably taking on VA-centric care, the real issue ought to be what is the readmission rate for the veteran, not where they're readmitted. Yeah. And the reason I think that's a big issue is, particularly as you look at studies that come out for VAs, there's some VAs that are very urban and they really have a more geocentric population like BU or some other, where it's a relatively small catchment area. Yeah. Others like ours actually serve everything from the ocean to the Sierras. Right. And I think that really affects the mix. So I'm a little worried that people are comparing apples to oranges.
Yeah, that the race might be a little bit higher than what we're actually experiencing. And that, but CMS ultimately will know, all the admissions that they paid for, no matter what the hospital's reporting. So that will be all rehospitalizations, and they'll know what the real rate is for patients, and they're going to count patients. On the Hospital Compare database, there's a description of how the calculation is and how there is some adjustment in those rates. Is that yeah? Yeah. Yeah, I'm not either. So we'll check and report later today about that. In our hospital, we looked at our electronic medical records to see who came back, but we also called people at 30 days to see how many went to other hospitals. And in our place, it was about 9% that did, and there was no differentiation between the intervention group and control group about how many went to other places, and that's in our data. But about 9% go other places in a place like that. I think here first. Or you have the microphone now.
Did you receive the discharge teaching reportings after you implemented private judge? Is there any differences in the amount of minutes spent or teach back, percentage of teach back?
Yeah, we didn't specifically measure it, but that the amount was lots more because the nurses spent up to an hour preparing that patient, collecting the data, packaging it, and teaching the patient. And teachback is part of the method, so that almost all those patients we think got teachback. We didn't measure; it could be measured, and later we'll talk about process measure. That's something that can be.
Was the
collected.
impact on staffing looked at all?
The impact on staffing?
Yeah. If
Yeah.
the nurses were spending
In
significant
our
more-
trial, the discharge advocates, the nurses, were paid from the research grant and were added on to whatever was done in the hospital.
Oh, okay.
So over time, the nurses on the wards knew the nurses, the project-read nurses, and would sort of stand back when it was discharge time.
It was a
So
dedicated nurse.
it was a dedicated nurse, right? Is that the only way that can be done? No, but we don't know what that impact would be exactly.
Okay, thanks.
I think it makes some sense that nurses who are on the wards, on the floors, who know the patient, know their medications, even know the families as they come in and out, could use those economies of scale that are built by doing that job, rather than building yet another silo that needs more communication to a discharge advocate kind of thing. Whether or not nurses who are caring for the patients can do additional duties is the pushback, of course, that is always given back to us. And that's why we think health information technology systems that teach the after-hospital care plan might make a whole lot of sense. I think here's next.
By the way, we're no different than national average for our admission rates.
Are you looking?
Yeah.
Look it up right now, because it'll say on there, whether
it's pretty complicated. They talk about a hierarchical statistical model, regression model, so I can't quite tell how it's actually reported.
Okay, thanks.
But yeah, have you been able to figure out, so from an outpatient point of view and involving them in the process, have you been able to look at folks that are still in the old school where they actually follow their patients in the hospital, and then they see them on the outpatient, and does that element, they don't have their nurse on the outside patient side necessarily involved, but do you know how that plays out?
Yeah, in our place, there are very few private attendings who come in to follow. They're almost all service patients. But clearly, this whole area of transition is a result of the loss of continuity from the primary care doctor following the patient in the hospital, caring for them in the hospital, and then knowing what to do. So people who do that, have done that for you, say, what's the big deal? There's no, I know my patients and all that. But clearly, things have changed. The growth of hospitalists is like this. The growth of hospital medicine is enormous. That the efficiencies built into that is probably here to stay. And that it has certainly challenged the hospital discharge transition enormously to build in, the hospital is separate from the community-based care, for sure. Do you agree with that?
Well, I think the most important thing here, Stephen, I want to draw your attention to is it sounds like John wants to do more inpatient time.
Yeah. And just one other question. For the pharmacy calls, did they actually schedule a time? Because we've been working on this, and AT&T, when my internet's down this week, they gave me a 12-hour window, and I noticed they said they would call that day or the next day, which is a 48-hour window. Have they tried just saying, we'll call you at this time?
Yeah, we tried to do that. We talked to the patients about the call, told them that there would be a call, and would put it on their after-hospital care plan. 2 days later, it would say, Project Red staff will call you on this day. Yeah.
Did you try a time? Like I noticed on yours, it literally said that day or the next day. Did you say we would call you, ask them what time works for them, and call them at that time?
No, but we should have. We did?
Yes. We actually had, on our beginning of the project, we said, what's a good time of day, what's the best number, the day of the week, and we get several options, and we gave that information to the pharmacist. So she would do her best to do, again,
yeah. Yeah, that's when we talk about the operational components, and these guys stand up and I sit down.
Going back to the earlier question about the discharge education, one of your slides indicated that discharge education was sort of ongoing through the hospitalization.
Yeah.
But how? I'm a little bit confused.
Yeah, how did that
if
happen?
There's a discrete discharge educator. Does that person come in just at the end?
Yeah.
Or did you incorporate that through?
Yeah, because they were discrete. So what would happen is that we would get a printout of all the admissions in the 24 hours before at 7 o'clock in the morning. It would print out, And then our research assistant would get that and then go through that to see if they meet eligibility criteria, et cetera. Go meet the patient and be sure they meet eligibility criteria. And then enroll them in the study with a consent form. And then collect baseline data like health literacy and the PAM measure and depression measure and all that sort of stuff. And then randomize them. And then if they're in the intervention group, they would then call the discharge advocate nurse who would come and meet them on that day, the morning after discharge. And then the discharge advocates would try to touch base with the patient each day of the hospitalization. Because like the stay is so short, that would only be a couple of days usually. So the first day they would begin collecting information, who's your doctor, where you go, where you're going to go, what are good days, all that sort of thing. And then on the day of, and then over time, what are the discharge medications, which is the hardest part of that part of the process. To get the med rec done is not so easy to do. And then to build the after hospital care plan and teach it on that last day. So we've tried to actually collect as much as possible as early as possible. And also the teaching about the diagnosis, about heart failure, about salt and fluids and weighing yourself and Lasix and all that kind of thing. And they would teach them about all that, which none of that happened at our place. None of that happened before.
Yeah, if I let everyone know kind of what we're thinking at the moment so that you know what direction we're going in. So first of all, we are moving forward with Teach Back in the inpatient areas. I met with all the chiefs of all the other nursing areas, and they're getting involved as well. So we will be creating some little like YouTube-ish videos teaching nurses how to do Teach Back in the inpatient and outpatient areas, including mental health. And so that we're already, so that the teaching starts at admission and works throughout. We're also looking at worked with Gloria to kind of repurpose some of our staff. We've realigned some case management. We realized that for the amount of discharges we do, it would probably take 2 people to do discharging at the discharge advocate level. So what we're starting off is one of our case manager FTE will be doing that, and we've just realigned how the teams are working at the moment. And we are going to take our patients who are being discharged in IPEC. There's a calculator so that the discharge coordinator can look at the day of the 12 discharges we're having, which of those ranks what percentage for readmission. So if 5 of the patients are at 5 or 10% and the rest of them are at 15, 20, or 30, then those will be the ones that the discharge educator will tackle for the day. And see how that works, and then see how we need to move more staff around. The inpatient nurses are creating a template right now for the communication to the outpatient teams, the GDOT teams. And so when a patient is discharged, it's a very brief template that is discharge diagnosis, discharge teaching needs, and then any transition of care issues that we have. We already know, and we heard some questions about patients being discharged at other facilities. We know that it's every patient, every admission. So we'll be working on getting that information to the primary care teams so they know what issues that we think may come up with that patient to prevent readmission. Additionally, we're working with surgical service in changing their discharge notes so that it's very clear, it's standardized the same way medicine has it, so that when a patient is discharged, we know clearly what that discharge appointment is and when it's needed and et cetera. We are creating a system where we will be working with the patients before they leave as to when can they come back for their appointment, and hopefully making that appointment that's more works better for them. And so that's in process at the moment. We're also, we do have our 48-hour callback already that we do. We have a standard script that we're using. We are looking at the data that we just received about our readmissions to see how we need to tailor that. The person who, the FTE that relieves that position will be a case manager, because we'd like to blur the line a little bit on the inpatient to outpatient transition. We would like for, if a patient has an issue when we call them that's an inpatient issue, that the inpatient team can solve that or resolve it or effectively hand it off to the outpatient team. I've met with inpatient doctors, Keith Posley And we have the same vision on trying to cure those problems the moment we hear them instead of waiting for that outpatient appointment. And I think that's pretty much it. I did want to say that as far as IT goes, we are waiting on Nebraska. When we had our technology meeting with the Project Red folks from San Francisco, they said that Nebraska was going live in August 15th. Now it's September 15th. And so I said, expect a phone call from us then. So I've talked with the team, Lily, the vice chair, and Alicia, who's been instrumental to our success. Talked with the project lead at Nebraska VA, and they're still looking like it's moving forward for the 15th of September for them. So we're waiting with bated breath to see how that turns out.
Yeah, thanks for raising that. Yeah, I think that in the process of teaching the after-hospital care plan, and especially through the process of teach-back, the discharge advocate gets a good idea of how well people are able to do what they're doing. And if they're not able to, then they should and did engage the family as much as they possibly can. And that for a nurse or whoever's responsible for the discharge to spend the time, teaching the after-hospital care plan to the patient, they're not going to necessarily spend that time teaching it to the family, although they can do it together, and they often did that. But having the after-hospital care plan, families really like, because it's clear to them what to do to help their parents. Yeah. For the Louise system, the IT system, then the family can then sit down and look at the Louise system and be taught the same thing that the patient was taught before, which is the after-hospital care plan. And families seem to like that quite a lot.
They're working on integrating the family caregiver into Project Red. They're starting to explore that. But also part of the discharge advocate, how to make an appointment for the patient is to say, how are you going to get this? And
typically say, my son's going to take me, or I'll get a ride there from a family member. So I think it does get brought up, but it's not necessarily explicit.
Looking at your baseline data for the various hospitals, did you notice a correlation between inpatient occupancy versus readmission rate?
Yeah, I don't know of that. Yeah. So yeah, but I think that inpatient occupancy has a lot. How full your beds are has a lot to do with how important readmission rates are, and that some people make the case that if your occupancy is high, then decreasing readmissions opens up beds for higher paying cases, for those surgical cases that can't get in, or the elective cases and that sort of thing, and that benefits the hospital. That's less important that if you have empty beds, so that those elective cases are already being able to get in. So for the higher occupancy hospitals, decreasing readmissions could be even a better thing, because it allows other patients to be admitted who are higher paying. Yeah, sure.
Getting back to that continuity with the PCP and realizing that it has widening between the hospitalist and the internist or the family medicine, has there been work done to get the primary care, perhaps nurse or team somehow involved when they're doing the teach back? It sounds like the money's in making sure the patient understands what's going on, but wouldn't it be neat to have the primary care's RN care manager virtually there at that time to hear what it is, so that at the follow-up they kind of are on the exact same page to kind of sync them up at that point?
Yeah. I think it would be incredibly powerful for that to happen. And the study was, Dr. Balaban has the study. There's only one out there like that. There's another in Maine where people did that sort of thing, where they set up these teams in the primary care offices, and that the nurse then connected to the patient. Sometimes went to the hospital, but often would call the patient in the hospital and then call them the day after discharge and connect them to the physician-clinician appointment within a few days. And I agree. I think that, in our review of all the literature, the programs that are effective are those that connect the hospital to the community. Either the hospital reaching out or the community reaching in. Both are best. There's no question about that. But there are a lot of studies out there that show no impact. And there's the Homer study in England that was done a couple of years ago that showed no impact. And even a few studies that show increasing readmissions, when the source of care in the community is really disconnected from the source of primary care and the source in the hospital. And that, our kind of explanation of it is that if a visiting nurse goes to a home and says, and has never seen the patient before, and say, gee, this patient is really sick, sends them back to the emergency room, and that happens, of course, can actually raise readmission rates. But if they know the patient from the hospital, then they know that they're way better than they were in the hospital previously, and are able then to go on with ongoing care at that point. So yeah, I think, and the literature is, I think, very clear about that the connection into the hospital and into the community is the key ingredient of the programs that seem to be successful. Ours reaches, the phone call part, and Coleman's program starts in the hospital and goes to the community after that.
The group in Maine, were they literally contacting the patient, or would they go through the inpatient team, like the nurse?
They would call the patient and say that we're going to be, your appointment is on this day, and give me a call. This is the number to call if there's any problems and that sort of thing. So
there wasn't then a team-to-team communication of like a brief?
I think maybe there was, but it was the key intervention was talking to the patient. Yeah, a lot of places, though, don't have the critical mass. The numbers from any individual place aren't enough, investing in. We're thinking about that with some of the community health centers. We have 3 or 4 big ones that admit to our hospital, and that's next on our agenda to look at that more specifically.
$8 hours time for the discharge nurse to have, ideal.
Yeah, how many patients can you do? How many discharges can a full-time discharge advocate do? That's a really good question. Yeah. From our studies, we don't know because it was research, and we enrolled 2 or 3 a day kind of thing because that was the right number that we needed for enrollment. The Boston HealthNet plan now provides Project Red to all their patients. So they've hired, actually, our research nurses now working for the Boston HealthNet plan, and their goal is 6 to 8 per day that they're seeing. They're not all discharges because they see all the patients. They enroll them on admission and then see those patients every day. So I don't know, 4 to 6 discharges or something like that. Actually, it might be more in terms of they see 12 or 14 and discharge 6 to 8 is the goal for discharges. Yeah.
Okay.
That's the key. That is the key metric, though, in terms of cost. How many can you do?
Again, everyone, please thank Dr. Jack for his presentation. Additionally, we'd like to say from the entire ARC grant work group, we'd like to thank Lisa Freeman and her leadership team for